Okay, so welcome everybody, and thank you for Project Echo for inviting me to talk about this topic, which is flow management as it pertains to period issues in teens as opposed to what you do in EPIC. So I have nothing to disclose, and hopefully what I would like everybody to get out of this talk is how to decide when a patient presents to you with period issues, is it normal or not normal? What evaluation should you do if it's not normal? And then make management decisions or options, or provide options if you're comfortable doing that. And that would include things that have hormones in it, such as birth control pills. So it is quite common that when providers start talking to their teenagers about periods, that you will have one of these three internal elicited reactions, which is okay, all right? Hopefully, when you complete this talk, I mean, you may still have these two reactions, but hopefully you won't have this reaction. So this is really just being able to give you guys a skill set and a knowledge set to be able to be more comfortable with dealing with period issues. From the standpoint of problem solving, when a patient presents to you, really knowing what the fundamentals are in physiology in regards to what needs to happen for a period to occur is really helpful, because then you can sort of identify where the problem is at. And most people don't realize that there's a lot of things that have to happen in sequence in order for a period to happen. So obviously it starts with the hypothalamus, which sends a signal to the anterior pituitary, which then talks to the ovaries, and hopefully ovulation happens with an LH surge. And then once that happens, the corpus luteum should be able to secrete progesterone. And then once you have estrogen and progesterone sort of doing its thing, you'll have endometrial proliferation. And once both of those hormones drop, then you should have withdrawal bleed, okay? This is a great graphic just to sort of understand when things happen, as well as if you want to educate your patients in regards to what happens with a period and where you might think the problem is happening. Okay, so what kinds of information do you need with your history taking? So number one, very important, is when did they start having a period, if they've had a period, okay? So that's incredibly important. We all know that in the first 2 to 3 years after someone starts having a period, it could be incredibly irregular, and that's normal because things have not matured yet. The other thing is, how many days are they bleeding for? Okay, and there's a normal and a not normal setting for that. Amount of flow. So this is an interesting topic because with a lot of teenagers, you need to know a couple of things. Number one, are they using pads or tampons? Are they using super absorbency versus regular? Are they changing the pad or tampon frequently because it's just stained, or are they actually bleeding through and filling those things up and they have to change it? Because that actually helps you decide how much bleeding are you really having, okay? So for a lot of teenagers, they feel like they're hemorrhaging their whole volume out. We all know this, okay? And so therefore giving them some perspective in regards to what's normal, not normal is incredibly important. All right, so how many times are they having a period in a given year? Are they having on average a period every month, or is it happening more often? Or is it happening once every 3 months or more than that? That's something that's important to know. Last menstrual period, also very important. So the first day that they started bleeding the last time is good information. Are they having any other symptoms? Are they cramping a lot? Are they having any premenstrual symptoms prior to them having a bleed? And then you start going into sort of pubertal development. How old were they when they started to develop breast? How old were they when they started to develop pubic hair? And then going into some more sensitive areas, are they having any sexual experiences? Are they using birth control? Are they using condoms? And that will allow you to know, do you need to do a pelvic exam or not? Do you need to do STI testing or not? Pap smears, obviously, we don't do in patients before 21 years of age, unless they have some sort of immunosuppression that makes them more susceptible to cervical cancer. Then obviously you'll go into your past medical history, medications, review systems, family history, and a HEDS exam. And all of those things are important to know because they can affect periods in lots of different ways, and we can get into that. Okay, so again, normal periods. For the vast majority of us, we understand a period once every month or once every 28 days is what's to be expected, but there is a range. You can have a period once every 3 weeks or a little bit longer than that, and that could be normal for that patient. In regards to flow, it could be anywhere from 2 to 8 days, and that can be normal. And then when you think about amount, it's 20 to 80 milliliters per cycle, which, how do you measure that? I am not expecting anybody to take someone's set of tampons and squeeze them out into a beaker and figure out how much that is. So don't do that, okay? Don't ask for that. I've had moms bring in a Ziploc bag a bunch of tampons so that I can see how much they're bleeding, which is both gross and incredibly unhelpful. So basically just asking them, what types of pads or tampons are you using? Are you soaking through them? Or are you just changing them every time you go to the bathroom? And that will give you a sense of, is it too much or too little? Okay, moving on with physical exam. Obviously you want to assess on first blush, do they look well or not? Are they super skinny? Are they overweight? Because that actually has some impact in regards to your differential. Vital signs are important to know. Is it stable or unstable? Because if they're bleeding a lot and they're hypovolemic, you need to know that. Weight, we've already talked about, because obviously if somebody is, let's say, obese, you think about PCOS. If they are super thin, then you might want to think about an eating disorder. And of course, you're going to get into that history and figure that out. Both of those things can affect periods. With your abdominal exam, you want to know if they have any tenderness in the suprapubic area or the abdomen in general. Are there any masses? Then you want to go into Tanner staging. And then when you go into sort of the gynecological exam, not every kid, and actually the vast majority of girls that have menstrual issues, do you have to do a speculum exam. At the very least, you should do an external genitalia exam, because that will give you some information, but not everybody needs a speculum exam, and more often than not, they don't need one unless they have had sexual experiences. And then obviously, as you're going through your exam, looking for other things like signs of hyperandrogenism and signs of insulin resistance, like acanthosis nigricans, can help with your differential. Okay, so as we go through this, I have little sort of picture slides that actually tells you how my mind thinks, okay? So there are sections that say no flow, and there are sections that are too much flow. There are sections that are like irregular flow. So if you want, you can think about when a patient comes in, they're telling you the story, like what picture flashes in your head. If they tell you they haven't never had a period, or the periods have stopped, this is what you want to think about, okay? So you break this down for those girls who come in and either they haven't had a period in a really long time or haven't had a period at all. The former is primary. So if they haven't had a period by the time they're 15, or within 3 to 4 years of pubertal start, so that would be breast budding, or within 1 year of reaching 10 or 5, pubic hair or breast. If they haven't had a period in any of these scenarios, then you have to start doing more of an exploration, okay? If they're coming in and they haven't had a period by the time they're 13, that could be normal. And sometimes what parents want is for you to tell them whether it's normal or not, okay? Secondary amenorrhea means they've gone through puberty, they've had periods at least once or twice, and now they've stopped. And they haven't had a period in, let's say, 3 months or 3 cycles. Because in some women, you know, they could have a period every other month or every 3 months, and that could be normal for them. So 3 cycles for someone of that sort of every 3 months is 9 months. So if they haven't had a period in 9 months, then that's an issue. If a girl comes in and they just missed the last period, obviously there are things that you think about like pregnancy if they've had sexual experiences, but if otherwise the history doesn't give you any sort of indication as, you know, so anything abnormal, you know, skipping 1 period is not something to get excited about. Like in cases like that, if otherwise there's nothing else that would worry me, I'm okay with watching for a couple of months to see what her cycles do, because there are reasons behind why that can happen, and we'll get into that as well. Okay, so primary amenorrhea. This is how, in my mind, I break it down. Is the problem in the head, which could be the pituitary or the hypothalamus? Is it in the glands, meaning the adrenals are not creating or using or has the enzyme that they need to actually produce androgens or hormones? Is there a problem with the gonads, meaning are the ovaries not working? Or maybe they don't exist? Are there testes? So maybe that girl is actually, you know, genetically a boy. Those things you need to know. Is the problem with the plumbing? Okay, is the vagina normal? Is the uterus normal? Does it exist? And so if you actually think about that from sort of head to vagina, that is one way to think about where is the issue in regards to a girl that hasn't had her period ever. Okay, so in the evaluation, a lot of these slides in regards to evaluation are pretty much the same from case to case. So first is the physical exam, all right? Is there breast development? If there's breast development, then you know there's estrogen in the system. That's important to know. Is there pubic hair? If there's pubic hair, then you know there's androgens in the system as well. Then you do an external genitalia exam. Is the vagina there? Is it a normal vagina? Obviously, you won't know if the uterus is there unless you have x-ray vision. So thinking about just, does the plumbing exist in your physical exam? All right, so starting from, those sort of physical findings. If a girl shows up, no period, no breast development, this 2 items are your differential diagnosis, which gives me a headache because when you see this on a board exam, they look almost identical, okay? So basically what you need to look at is it hypergonadotropic or hypogonadotropic? Hypogonadism just means that the ovaries are not doing what they need to do, all right? Hypergonadotropic means that the signals from the brain are being sent, but the ovaries are not responding, okay? The differential for that includes Turner syndrome. It could be that there's gonadal dysgenesis. There could be 17-alpha hydroxylase deficiency, which is a type of congenital adrenal hyperplasia, or the ovaries have failed, which is very rare, okay? The opposite end of the spectrum is the signal from the brain is not happening, therefore the ovaries don't know they're supposed to do something. And that differential includes things that involve the hypothalamus. It could involve problems with the pituitary, or commonly it's constitutional delay. Okay, so obviously with a lot of these things, there are certain things on physical exam, for instance, like with Turner's and with Prader-Willi, like there are things that you will see on exam that will indicate what the differential is sort of geared towards. But for the most part, a lot of what you're going to be doing is lab workup to try to figure out where the problem is. Okay, so what if a girl, no period, doesn't have pubic hair? Then what you want to think about is something called androgen insensitivity, which more commonly used to be called testicular feminization, but we're sort of, veering away from calling it that because people used to call these patients, oh, they have TFEM, which is slightly negative. And so therefore, in this case, those patients phenotypically look female, but biologically are male, okay? And what's happening is the external receptors for male development are not working, and therefore the androgens are basically not working, and so therefore externally they don't develop the male physical characteristics that you would expect, and therefore they're actually XY, even though you think they appear phenotypically female. There are a lot of famous people out there who have androgen insensitivity, one of whom is Jamie Lee Curtis. Interesting, and she's a beautiful woman, obviously. Okay, moving on. What if they don't have a uterus? And you check this by doing an ultrasound. It could either be androgen insensitivity, which is we just talked about. It could be because there is no uterus, otherwise known as MRKH or Myrick-Katansky-Kuster-Hauser, of which I've seen 2 cases of this. Or they could have 17-alpha hydroxylase deficiency and are genetically male. Okay, and that is a type of congenital adrenal hyperplasia. Other thing, oh, there you go. So basically, if you want to talk about androgen, steroids, and hormone synthesis, and by the way, I just had PTSD. Every time I see this chart, I get PTSD because it's sort of like a board question and you're supposed to memorize this chart. But this is actually a really great way to figure out, what happens when there are deficiencies, okay? So what I just talked about is 17-alpha hydroxylase, which is here, okay? If this does not exist, if a patient actually has a deficiency in this, basically you have a block right here, all right? So there will actually be no production of any of these steroids or androgens, and everything gets shifted down this way, all right? So that's something to think about. The other thing is again, thinking about plumbing, like what are the issues there? You can have multiple different molar duct anomalies that could cause someone to have primary amenorrhea. If they have a lesion, one of these, that is obstructive, all right? Or in a case where there's actually no uterus really. I mean, there is, but there's no cavity in order for there to be a uterine lining. So this is also things that you might want to think about, which you will catch when you do an ultrasound. Okay, so what if when you do your external exam in someone who's never had a period, they may have an abnormal vagina? So the classical thing is the girl who comes in with cyclical pain of the abdomen, but there's no period. So they feel like they're going to have a period, but they just never do. And you do an external exam, and what you find is the stereotypical bulging blue sac of fluid in the vagina, okay? And this is an imperforate hymen. What I wouldn't have you do is try to poke this and pop it like a balloon, okay? Not a good idea, okay? First of all, because you actually don't know how much blood is behind that imperforate hymen. And if you were just to poke it with a scalpel, you might get a lot of blood coming out, which would not only be messy, but somewhat dangerous, because if there's a lot of fluid back there, you can cause a patient to go into hypovolemic shock. So therefore, they need to be referred to surgery so that they can, in a controlled environment, open that up, do what they need to do to keep it open and drain the fluid out. The other thing that's very similar, but you wouldn't be able to see on physical exam, is a transverse vaginal septum, which is higher up. So you wouldn't be able to see that unless you do a speculum exam. And I actually just told you, not all kids need a speculum exam. The way you would see that is if you do that exam, which is a possibility, or you do a transvaginal ultrasound. You wouldn't be able to see this on a transabdominal ultrasound, because that would only show you sort of upper area of the reproductive tract. All right, so that's something to think about when you think it's sort of a blockage lower down, but you don't see this, it actually might be this, okay? And that needs to be sent to surgery. All right, what if you get the girl that has a normal physical exam, which is by far much more common than the other two things that we talked about. It could be idiopathic or constitutional delay, and how you can find this out is in the family history. All the women in the family tend to have their periods much later, when they're 14, 15, 16, okay? They might be on medications. They might have stress. So stress, obviously very common in teenagers, so that might cause it. Extreme exercise, or someone who's in athletics because they have very low body fat percentage. It could be that they've lost a ton of weight, and so that's actually inhibiting them from being able to get a period because the hypothalamus is suppressed. It could be a pituitary condition. It could be an ovarian condition, which again is rare. It could be the uterus thing, because obviously you can't see the uterus just on physical exam. It could be because they're pregnant. Unfortunately, I've had patients who actually had sex and thought they couldn't get pregnant because they've never had a period, and unfortunately they got pregnant before they had their first period. It does happen, which is why you should always do a pregnancy test in anybody who hasn't had a period within the last 30 days when it's expected. Chronic illnesses can cause hypothalamic suppression as well. And then thyroid disease is always part of the differential whenever a period issue is being presented to you. Okay, so how do you evaluate? Again, and this is very common in all the different scenarios that I'm going to talk to you guys about. Full history, physical exam, external gynecological exam, Tanner staging, and then you get into the hormonal workup. So this is sort of my baseline, first line hormonal workup for all patients that have period issues, okay? Part of why I do that, and this is when they sort of meet the criteria for I am concerned. I wouldn't do this on every teenager that comes in who's, let's say, 14 and haven't had a period yet. I mean, it's those girls really who are 15, 16, they've gone through pubertal development, or maybe they haven't, and they haven't had a period yet. But this is what I do, because the likelihood is you're going to find your answer in this hormonal workup. And the other thing is, especially for those girls who have secondary amenorrhea, if you're going to do any sort of hormonal medication treatment, you always want your baseline first before you start hormones in the form of birth control pills or some other format, mainly because once you start hormones in this girl, a lot of these hormone levels will change because they're influenced by the medication you're being given. And so then that window in which you can actually see if they have a baseline condition goes away, because now they're going to be on hormones and a lot of these levels are going to be changed. On exams, if anybody is about to recert or take their shelf, if they ask you, if you had one lab you want to order to see where the issue lies in someone who has primary amenorrhea specifically, it's the FSH, okay? Because that will actually tell you if the problem is upstairs, like in the head, because that will tell you whether the hypothalamus and the pituitary are working versus not, okay? Because it will be low if the signals aren't happening. All right. And these are all secondary tests that you can do depending on the history and the physical exam that we just talked about. Doing karyotype to see genetically, are they male, female, doing the pelvic ultrasound to see what the plumbing is like inside. If you're worried about a pituitary issue, ordering an MRI with and without contrast, specifically through the sella turcica, because that will give you the slices through the pituitary. If you just order an MRI with and without of the brain, they may not give you sort of the close look at the pituitary that you want. So you have to specifically order this. The CBC, the BMP, CMP is mainly to look at chronic, whether this might be a chronic illness or not. And then if you have someone who has some, delay in pubertal development, you might want to do a bone age to see what age their body thinks it is, because that will give you an idea of what timeline you should be looking at. All right, management. If you figure out that a adolescent has hypogonadism, they're going to need estrogen therapy with progesterone eventually. I mean, these are cases that honestly I will involve my endocrine colleagues. I wouldn't do this myself. If it turns out the patient is XY or a genetically male, but they are phenotypically female in the conditions that we talked about, the gonads need to be removed because they are sources for cancer in the future. If they don't if they don't have a uterus, some things that you can do, and I've done this, is actually, doing vaginal dilation if they do have some vagina, or they can actually go to plastics and get a vaginoplasty. One of the things in a patient that doesn't have a uterus that you find out, always check the kidneys as well, because there's a strong association with issues with kidneys and someone who doesn't have a uterus. Sometimes it's a malformation where there's maybe a horseshoe-shaped kidney, or it could be that one of the kidneys is missing. So there's a strong association. If they have a prolactinoma or they have a vaginal obstruction, obviously they should go to surgery. If they have constitutional pubertal delay or normal physiological delay based on your physical exam and history, most of the time you can just observe, okay? Down the road, you can offer hormone therapy. I wouldn't do it before the age of 15, 16. You should give them every opportunity to have their first period naturally. And also to make sure that if they've gone through pubertal development, with the exception of the period, you want them to maximize their growth potential before you start giving them hormones. All right, secondary amenorrhea, the differential is very similar with the exception for sort of organ abnormalities, okay? So it could be all those things. I think the only exception is in regards to the pituitary. If they give you a history that they've actually been pregnant in the past, you can actually get an infarct of the pituitary and then they lose their periods, okay? That's called Sheehan syndrome. The other condition is, again, if they've been pregnant in the past and they've had an abortion or a D&C, you can actually get scarring on the internal walls of the uterus, and now the internal walls are stuck together, so there's no cavity for an endometrial lining to develop. That's called Asherman syndrome, okay? And then, all these other things are very common are in common with primary amenorrhea. We'll talk a little bit more about late onset congenital adrenal hyperplasia in upcoming slides. Okay, so this is going to get repetitive. So hopefully this sort of reinforces the things that we're talking about. Evaluations, history and physical exam, the hormonal labs are essentially the same. I think one of the things that's a little bit different in secondary amenorrhea is that you can do a progesterone challenge, which is essentially progesterone pills called Provera that are 10 milligrams. It's a once-a-day pill. You write a prescription for 10 days. They take one each day, and within 3 days of the last pill, they should bleed, okay? If that is the case, then pretty much we're good to go. And we know that that they can have a period and so forth. Sometimes with this sort of jump start, they will actually start to have a period every month or every couple of months, which is fine. Usually in these cases, the labs are normal. If it's not, obviously you'll do the appropriate thing. Like if there's an increased prolactin, you want to see a CT or an MRI of the brain. I prefer the MRI. If they don't bleed, don't panic. One of the other things that you can do as a subsequent step is to start them on combined oral contraceptive pills that has estrogen and progesterone in it. Usually they will bleed at the end of the pack. In cases like this, go back and look at your FSH or do the FSH if you haven't already done it. Hopefully you have had, and then check to see if it's low or normal. In that case, you want to maybe check a CT or an MRI, and it's usually normal. So then you can actually be reassured it's probably hypothalamic suppression. If the FSH is high, that means the ovaries are not doing what they're supposed to do. Then you want to check other things like that we already talked about. Are the ovaries there? Are the ovaries failing? There's a whole other lab work set that you could do with that. If they don't bleed, even with the birth control pills, and they have a history of having been pregnant in the past and having D&C, then you worry about Asherman's. I, to date, have not had a case where they haven't bled with either the Provera challenge or the pill combination. So this is a lot less common, and obviously you're going to take this history as to whether they've been pregnant or have had a D&C. That's not something that's, you know, obtuse. I mean, you could, I mean, the only thing that maybe is if you didn't ask, they didn't tell you, or they didn't tell you even though you asked. So it's something that I think when you go through this sequence of events, you know, getting more history is important. All right, so let's get into cases. First case, 14-year-old girl who had her first period about a year ago, flows for 10 days. It's heavy. It happens every 2 weeks. She's not having any cramps or pain with it. She's soaking through pads every 4 hours throughout the 10 days. Every single woman in the family has had the same pattern of periods since their first period. What are the things that you think about? Okay, so the things that sort of like, you know, stand out is number one, she only just started having a period about a year ago. Okay, so it's pretty recent. The flow is pretty long. It's pretty heavy. She's soaking through pads. Like, that's a lot of pads. Okay, for me, that's like a lot of bleeding. And then for this, you know, that's a heads up, because really, you know, period issues tend to run in families. So being able to get that history is important, because this triggers for me that there might be some sort of bleeding disorder in the family. Okay. Other things you want to know: does she have like bleeding from the gums? Does she has easy bruising? Has anybody told her she has a bleeding issue? So those, or anybody in the family have bleeding issues. So these are things that you want to take into account when you get a history. All right, so this is the picture in my head when I think too much flow. The dam is broken, okay? And so menorrhagia, and by the way, there's menorrhagia, like there's so many medical terms that you can use. If you can't remember what they mean, either look them up or just use descriptants, okay? So this girl, I hopefully will all agree that she's bleeding a lot. So in your differential is pregnancy with a spontaneous abortion. She could have a bleeding disorder. Thyroid disease is always part of the differential. If she's had sexual experiences, she might have PID or an STI, because I've seen one case of this where it's caused endometritis and they're having a ton of bleeding plus pain because they have an STI. There could be trauma, unfortunately, or there's a foreign body in there that's now sort of created a hole, and now there's like bleeding, you know, a vessel that's broken open. Abnormal uterine bleeding is a thing that's always high on my list of differential in cases like this, especially given the history that this girl is giving. And that is due to an immature HPO access, and there's not ovulation happening because it's too early in this girl's development. But AUB, which was previously known as dysfunctional uterine bleeding, or DUB, is a diagnosis of exclusion. So you have to make sure there's not other things going on before you call it this. All right, what's your evaluation? Again, none of this is new to you guys, you know, so many slides in. Sort of additional things you want to do right off the bat is you might want to do orthostatics to make sure they're not hypovolemic. You want to check a hemoglobin stick just to see where the hemoglobin is at, because that will define for you, both of these things, what your immediate management is going to be. Menstrual journaling, I actually, with any girl that's referred to me or tells you that they think their periods are irregular, doing a menstrual journal is never the wrong thing. And there's so many apps now that you can download for free where they can track their periods. It makes it easy to know normal, not normal, right? Obviously do a pregnancy test. I do this on all girls, even if they tell me that they're not sexually active. It's just good medicine to be able to document that the pregnancy test is negative. And then doing, you know, preliminary hematological evaluation is good. All right. And then I will tell you, most of these girls, if not all, will end up being on hormones to control the bleeding if the bleeding is bad enough. So basically doing hormonal studies is important to do up front. And then all the other things are depending on the story. Pelvic ultrasound, do I do that often in girls who have heavy bleeding? Not really. But if you're concerned that she has a partial abortion going on, they might need that regardless. And then STI testing, obviously, if they've had sexual experiences. All right. So back to this diagram. How does anovulation cause excessive menstrual bleeding? So in the first 2 to 3 years after the period happens, it's really common, okay? Not only is irregular periods common, I shouldn't say that. Irregular periods are very common. Excessive bleeding is far more common in the first 3 years than after that, okay? So it can happen. So in the physiology, what happens is there's no LH surge, okay? If you don't have an LH surge, you don't ovulate. Okay, if you don't ovulate, you don't get a corpus luteum. If you don't have a corpus luteum, then you don't have secretion of the progesterone. Okay, and all these things have to happen to have a normal period. So instead, when you don't ovulate, all you have is estrogen, and the endometrial lining is being influenced by estrogen to just grow. All right. Then what happens is you go one of two pathways. Either the follicle involutes, and then estrogen drops, and then you have a withdrawal bleed because of that, or you don't get that, and it's just estrogen all the time. And basically the estrogen is telling the endometrial lining to just grow super thick, and what happens is it outgrows its blood supply, and the top layer just sloughs off. And that happens continuously, all right? And that's how you get prolonged bleeding or lots of bleeding. That's what happens when anovulation is the issue in cases like this, okay? So then what do you do next? Okay, it depends on whether they're actively bleeding when they see you or whether they're symptomatic. If they're neither of those things and your hemoglobin is, you know, in a comfortable range, you can reassure, educate, do iron supplementation because they're probably iron deficient from all the bleeding. You can either observe or put them on hormones, such as the birth control pill. You definitely have them start to journal and track their period. P-Tracker is actually one of my favorites. I don't get money for that. It's just the easiest one for patients to use. And then you follow up, okay? And therefore, you know, you just make sure that it doesn't get worse. You make sure that their hemoglobin is stable and they don't become anemic. And then you follow them over time. So what do you do if they're bleeding in your office and or they are symptomatic? Then you want to do vital signs such as orthostatic blood pressure. You do a stat hemoglobin. If they're sexually active, you want to do a pelvic exam and do STI testing. And then you, depending on the history, actually, no, we do this on every, well, that's not true. If it's excessive enough and they're anemic, you want to think about sort of additional hematological workup and or involve your hematologist, okay? It's really funny because a lot of patients with this condition probably get referred to hematology first before they get to me. And I think the hematologist would prefer I see them first and make the decision and then refer to them if need be. But we share a lot of patients. So therefore, you can't go wrong, to be perfectly honest with you, if you're concerned about someone who has menorrhagia. Okay, so management. So a lot of it, like I said, was based on hemoglobin and symptoms. You have to decide, admit, or can you manage as an outpatient? And how you decide that is what their hemoglobin looks like, as well as symptomatology. If it's mild, my cutoff is 11. So if it's above 11, it's mild. We can follow it over time. You know, birth control pills maybe or maybe not, depending on how the parents feel. If it's moderate, which is 8 to 10, you know, I probably take a stronger stance in regards to trying to put them on birth control pills to control the bleeding. If it's severe and the hemoglobin is less than 7, then I admit them, okay? And I actually just talked about this. So this is what you do with mild AUB. This is what you do with moderate AUB. Okay, and the reason why I put this up here is I think there are a lot of parents out there who do not want their teenagers, especially young teenagers, to be on birth control pills, okay? Because they're scared about the dangers, they're scared about the side effects, they're scared that once you start them on birth control pills, they're gonna go straight out and start having sex. I feel like that's like the more common concern that they have, which by the way is not the case, but you know, I can only convince them so much. But if they're open to it because they understand that the danger of becoming anemic, these are the things that you can do to control the bleeding. If they're not actively bleeding, you can start them on the pill and just see how it goes. If they're actively bleeding, the thing that you want to do is stop them from bleeding, right? So these are the moderates. Their hemoglobin's about 8, 9, 10. When you pick out the birth control pill, make sure you choose a birth control pill that has at least 35 micrograms of estrogen in it, because if you use the lower estrogen pill, which I think a lot of community pediatricians are very comfortable with, you know, such as Lolo, great name. The problem is with the lower estrogen pill, they tend to have a lot more breakthrough bleeding. There's some less control with sort of the lower estrogen pill, so I tend to go with the higher estrogen pill. My preference is low ovaral. Again, I don't get any kickbacks from that. It's because the progesterone in low ovaral, for whatever reason, helps stabilize the progesterone lining. Helps stabilize the endometrial lining a little bit better than the other pills, but you can actually use any pill, whatever insurance will cover. If you want to get them to stop bleeding right away, there's 2 methodologies. I was taught the 4-3-2-1 method, which is 4 pills a day for 4 days, 3 pills a day for 3 days, and so forth. and then you keep them on the active pills until the hemoglobin is greater than 10. Okay, and how you do that is you tell them to punch out the last 7 pills of the pack, which are placebo pills, and then you just use that until the hemoglobin is at a good level. The easier method, and by the way, you're gonna have to write this out for the patient so they know exactly what they need to be doing. The easier method is actually to have them do 4 pills a day until they stop bleeding or it slows down, which usually happens within 1 or 2 days of doing this, and then go to twice a day for about a week to 10 days, and then drop down to 1 pill a day. This is what I call the OCP wean on both of them. I wouldn't drop down to 1 pill a day too quickly because they'll start bleeding again. All right, so be aware of that. All right, and then, you know, once they get to a good hemoglobin that you're happy with, you can allow them to have a short withdrawal bleed by having them punch out the last 4 pills of the placebo week so that they only bleed for hopefully 3 or less days. Because hopefully all of you know that placebo week is when you get the withdrawal bleed because all the hormones drop. Some kids are very sensitive to the birth control pill, the hormones in it. So obviously if you're doing high dose, what I consider high dose, so it's 4 pills a day or 3 pills a day, they might get nauseous, so you might need to prescribe them an antiemetic. But warn them ahead of time that this is a possibility so they don't freak out. Okay, and then I usually continue to have them cycle on the birth control pills for at least 3 to 6 months, especially for those parents who are really worried about their teenage girls being on the pill. And then after 3 to 6 months, I'll take them off the pill and see what their bleeding does. If miraculously their HPO axis has figured things out and now their bleeding is not so extreme, they can go about their business. But if they start to bleed heavy, which may happen within 1 or 2 cycles after you stop the pill, then I put them back on the pill for another 6 months and then try again. Okay. Because if this is truly AUB, then usually within 3 years of menarche, this should all be better. Keep in mind though, if those girls have a bleeding disorder, you know, they probably are going to need to be on the pill until they're ready to have babies, okay? Because otherwise they'll just have so much bleeding, it's gonna be an issue. All right, then you follow them up weekly and then monthly when you know they're stable. Okay, if they have severe AUB, and as you remember, if their hemoglobin is 7 or less, they need to be admitted. They need IV fluids plus or minus a blood transfusion, although I will tell you sort of the tendency is to do blood transfusion if the hemoglobin is less than 7. What I have been trained to do, which a lot of people don't really do anymore, is do IV estrogen at 25 milligrams every 4 hours. Until the bleeding slows or stops. But a lot of people are uncomfortable with IV estrogen because they're concerned that if this girl happens to have some sort of coagulopathy or hypercoagulability that you don't know about, you're going to cause clots to form and then, you know, all sorts of dangerous things happen. Knock on wood, in my career, you know, using IV estrogen has not caused anybody to have a PE. And I can tell you, if this is truly AUB, the IV estrogen will make it stop within 4 doses. But many providers may not be comfortable with this, and we'll talk about that. Along with the IV estrogen, we'll also add in the birth control pill because you want progesterone in the system as well. So what IV estrogen does is there's a negative feedback mechanism that allows the bleeding to stop. Okay, now, having said that, you don't go over 4 doses on inpatient. Basically, if they don't stop bleeding on 4 doses, something else is happening. And it's not what you think it is. The differential is different. And so if they don't stop bleeding with the 4 doses, then they need to go to the OR to have someone look. OB needs to go in there and look to see what's causing the bleeding. I think the one time in my experience where the IV estrogen didn't work is there was actually a blood vessel in a girl's uterus that was exposed and it was just pumping out blood. They had to cauterize it. The other option that you can do is instead, I mean, obviously they still need to be admitted if their hemoglobin is that low. Instead of doing IV estrogen, you could just do the increased OCPs that we talked about, which is like, you know, the 4 pills a day until they stop bleeding and then do a wean. Okay, then after hospital discharge, you do the taper and do a lot of the other things that we talked about in the other the other levels of AUB that we talked about. Okay, case 2. 15-year-old girl, history of irregular periods, no menses in the past 9 months, lots of acne, BMI is on the high side. What else do you want to know? Are there other things going on in regards to her history? So this is irregular flow, and you know, this is where you worry about irregular periods being caused by increased androgens, which the differential includes exogenous androgens. So that it maybe, I have had one girl where she was buying supplements from GNC where it includes androgens. She wanted to get some muscle building, and it was because of that, and that's why her period stopped. So I had her stop doing that, and her periods came back. PCOS is the most common thing. Adrenal or ovarian tumor is less common, and then late onset congenital adrenal hyperplasia is the other part of your differential. So when you look at androgen producing tumors, they could be from the adrenals or the ovaries. For you all, when you do your lab work, you know, when you are concerned about an androgen producing tumors, usually the testosterone is up to 3 times more than normal, as opposed to PCOS, which is higher than normal, but not to that degree. Okay, and then you do the workup as appropriate. And I'm watching the time, so we're going to go through these a little bit quicker. When you look at late onset congenital adrenal hyperplasia, it's usually 21-hydroxylase deficiency, although it could also be 17-alpha. And then, you know, your lab work will actually help you suss that out. But PCOS is probably the most common thing that I'm seeing. The exact cause is not known. And when you don't know, it's usually multifactorial. And there's a lot of different things that are going on that cause PCOS to happen based on my reading. And it's all sorts of things, as you can see from this graphic. Now, the classical presentation that we all know is the irregular periods, hirsutism, increased acne, obesity, and acanthosis nigricans. Be aware that there's a non-classical presentation where a patient doesn't have any of those physical symptoms. They just have irregular periods. And then when you do the workup, you have an increased free testosterone, and you also have an LH-FSH ratio that's greater than 3. Now, you can actually have someone who has more than likely PCOS, but at that moment in time, the free testosterone is normal. I would still treat them like PCOS because they're at high risk, and just address it accordingly. What about the Rotterdam criteria for PCOS? We don't use that really as an application towards adolescents because adolescent presentation is just different from adults. I don't do a pelvic ultrasound to look for cysts in the ovaries unless the patient has pelvic pain, all right? Because it's not going to change how I manage that patient. All right. And we all know that PCOS is not a benign thing. There's a lot of things that are associated with PCOS that we need to be aware of. It's better to treat than not treat. And most girls, honestly, that present with this, they want regular periods anyway. So more likely than not, I'm going to start them on hormones. But I will do the hormonal evaluation beforehand so we know what their status is. Treatment is weight loss and healthy lifestyle changes if they are obese. The most common management that I use is OCPs. You can also use other hormone-containing options. The implant in the arm is the only option that will not work for PCOS. None of the literature supports that, so therefore I don't offer it as an option for PCOS treatment. Metformin, if somebody does not want hormones as a treatment, is something that you can use as well, mainly because it suppresses ovarian androgens. It helps with insulin insensitivity if they do have that. Old school treatment is spironolactone. I tend to not use that just because it won't make the periods more regular, which is what most girls want. And then Vaniqua is to retard hair growth if that's the biggest concern, although in my population it's not. All right, case 3, 12-year-old girl with menarche at 11. It occurs every 3 to 4 months, flows 3 to 8 days, no pain with periods. Otherwise normal sort of setting, except it's happening once every 3 to 4 months. Like, what do you do about that? To be honest with you, the likelihood is it's immature HPO axis. You can offer birth control pills if you want to, but it's caused by lots of different things that are benign. You can do the evaluation without doing any hormonal workup at this point based on her presentation. And you can just observe and have her journal. But if this is still occurring 3 years beyond menarche, then you can do a workup. So that's this case, and we all know what the workup is by this point. And if that's all normal, then that's just how she's built, and that's okay. Some girls have a period once every 3 months, and that's normal. If she wants a period every month, because for her that's what she wants to feel normal, you can offer birth control pills to make it happen every month. Okay. Yes. Sorry. Oh, okay. Case 4, 17-year-old girl, menarche at 12, so we're 5 years beyond it. Flows pretty normal, but she's having a lot of pain and nausea and vomiting. What else do you want to know? So here's the deal. Dysmenorrhea is a real thing. In some girls, it's very severe, and there is management for it that you can offer. It's not just pelvic pain. You can have GI symptoms and headaches. It can be that bad. So be sensitive to that. If you manage the primary dysmenorrhea correctly and they're still having pain, then you need to think about secondary causes such as endometriosis. And that you need to treat the underlying pathology, which usually includes you referring them to OBGYN to make that diagnosis of endometriosis. So management. First thing you should do is offer ibuprofen, naproxen, or non-steroidal anti-inflammatory. The key to this is appropriate dosing, starting 1 to 2 days before they start to bleed. It needs to be scheduled, and you need to continue it on until 1 to 2 days after flow starts. Basically, what you're trying to do is have the level of NSAID in the system so that it can block the prostaglandin from telling the uterus to squeeze. So it's very a proactive and preventative way to treat dysmenorrhea, as opposed to waiting for the cramping to start. Then by that point, it's going to take a while for any of your medications to work. If that does not work, then you can add on birth control pills, okay? All right, last case. 15-year-old girl, medically complex, non-ambulatory, non-verbal, severe seizure disorder, lots of contractures of the joints, lots of medications. Menstrual history, menarche was within the same year as the referral. She's only had 3 periods, which were actually regular at this point. Bleeding is not extensive in regards to days or amount, and the mom would like period suppression for hygiene issues and contraception. This is incredibly common, all right? And I think back in the day, I offered Depo to everybody, all right? New articles have come out where you really want to explore the reasons behind why they want suppression and go through the reasons behind it. And probably the most common things are hygiene issues and basically concerns about those patients being taken advantage of and sexually abused, and you don't want them to become pregnant. But there are other reasons that you can use suppression of period, you can suppress periods, be aware of that. And then these are the different options you can use. I think the one that's actually being suggested more often by our OBGYN colleagues is the Mirena IUD. You could also do Depo out of the office. And then you could use other methods, just to use them continuously where there's no placebo week. But it usually takes about 9 cycles on one of these methods to actually get to amenorrhea, but you can do it. But there's a lot of things to consider, especially in this case. Number one, I would never start hormones on someone who hasn't had a period yet, unless they're 16, 17, okay? You need to think about contraindications. One of the best ways to look at whether you can do hormones on someone or not is using the CDC's MEC, which is the MMWR, which looks at this. So these are the absolute contraindications to any medication that has specifically estrogen in it. And for our population, it's really, the things that you think about are migraine headaches with auras and anything that causes, that's sort of a predisposition for hypocoagulability, such as lupus. Okay, but you can look at this, and there are other reasons why you wouldn't use hormones on somebody, especially those that have estrogen in it. And I always look it up because I want to make sure that I know what I'm talking about. In this particular case, the other things you want to think about is medication interaction, because starting someone on hormones who also is on anti-seizure medication, those 2 medications can affect each other in different ways. You want to think about whether long-term options of progesterone only, such as Depo, will affect bone mineralization, causing osteopenia. You want to think about those kids who are immobile, that they might be at more risk for thromboembolic events. And then sort of adherence and tolerance of method is always a consideration. I am done. I love this. I'm a New Yorker, so I just find this funny because it's so real in our life right now. Are there any questions? I am right at 1 o'clock.
Yeah, thank you so much, Dr. Barangan. Great information that you shared with us today. So yeah, we'll open it up right now for questions from the group. I think Dr. Shane, did I see you unmuting yourself? Do you have a question?
No, that was by accident. No questions. That was an awesome presentation. Thank you.
Thank you.
Question here from Rick. Does IV estrogen or prolonged estrogen use or birth control at a young age place patients at increased risk of cancer in later life?
That is a great question. You know what's really, the IV estrogen, I don't know, because nobody uses IV estrogen long-term. That is purely a intervention that you use for someone who's bleeding so badly that they require hospitalization. When you talk about long-term in regards to putting someone on birth control pills, it's actually protective against endometrial cancer and ovarian cancer. Now, having said that, if there's a family history of hormone-sensitive cancers, I think twice about putting them on hormones, okay? But in our age population, that risk is so incredibly low that it's not something that is high on my list of, oh, I should be worried about this. I mean, for me, there is a long history of populations being on hormonal birth control for years and not having any issues. I think the thing that most people worry about, if I'm going to speak for the general pediatric population of which I am a family of, is, what is the risk of causing someone to throw a PE, for instance, by putting them on birth control pills, okay? So here's the deal. If there is a family history of hypercoagulability, I will try to steer them towards progesterone only, because even though the risk is not zero, it's far less, okay? I also, consult with my heme colleagues to see if they need to go through a hypercoagulability workup. But if you actually look at what point do girls become more at risk for hypercoagulability, it's when the pill has more than 50 micrograms of estrogen in it. And most of our pills are 35 or less. Okay, now to give you perspective and relativity, a girl who becomes pregnant is more at risk of throwing a clot than a girl that gets put on the birth control pill. So it's relative in regards to what risk is. And if you do your screening appropriately to make sure that they don't have a predisposition, that's the most that you can do. But obviously when you do your counseling, you let them know that there is a possibility, okay?